Good evening. My name is Eliana Galliolo, and I will be your facilitator for this evening. I would like to welcome you to the Dementia Friendly Northern Prince George's County webinar. Tonight, we will be presenting Medicare, presented by Mark A. Gottlieb, President of Gottlieb Insurance Advisory. Without further ado, it is my pleasure to welcome Mark Gottlieb. Our speaker tonight is an independent insurance broker who offers a wide array of products to persons of all ages in order to assist them in protecting themselves and their loved ones. He is appointed to offer products from a large number of well-known and well-rated insurance companies. Mark has served as a captive agent for several large insurers, including New York Life, but prefers to work as an independent agent and broker so that he may offer whichever product on the market offers the greatest value to his clients. And without further ado, here's Mark.
Hi, good evening, everyone. Nice to have you here. Looking forward to spending the next hour or so with you and hopefully helping you to understand this somewhat complex array of coverages known as Medicare. It's an especially timely opportunity to speak with you because we are quickly approaching what's called the annual enrollment period, which will be on my very next slide. But that starts October the 15th, so we're coming up, goes through December 7. It's a time when people can change their Medicare Advantage and prescription drug coverage, which helps to supplement what the federal plan offers. Specifically, there's A and B, Part A and B. We'll be discussing that in detail tonight, as well as Part D, prescription drug coverage. And there are other things, including Medicare Advantage plans, which are known as Part C, Medicare Supplement plans, also known as Medigap, and the new plan, Medicare Savings Account, which is like an HSA account for the 65 plus population. So we'll be covering a lot of ground. Tonight we'll be talking about A, B, and D, and in the subsequent presentation, we'll be addressing the Medicare Advantage, Medicare Supplement, and Savings accounts. So there are a number of enrollment periods, which are on the very next slide. And the first one is going to be what's known as the initial enrollment period. Sometimes you'll see that written as ISEP, initial coverage enrollment period. As you're approaching 65, I don't know the audience tonight, so I don't know how many people are approaching 65, getting ready to enroll in Medicare for the very first time versus those who've been in it for a number of years. And either way, this is important information for you to know. But the initial enrollment period starts 3 months before a person's 65th birthday and goes to 3 months after. So there's actually a 7-month period. Most people will sign up just shortly before their 65th birthday. I mean, you can sign up 3 months before, but it really wouldn't go into effect until your 65th birthday anyway. There are other reasons why people can enroll in Medicare, and we'll be talking about that in subsequent slides. So really, there's a full 7-month period to enroll. Now, there is something called a guarantee issue for Medicare supplement insurance for 6 months after you sign up for Part B. So as we get further into the presentation, I'll be talking about that. So in addition to initial enrollment period, there's something called the annual enrollment period, which I just referred to, coming up on October 15th, and we'll go through December 7th. And that's a chance for people to change the types of coverage they have. So for instance, you're going to be seeing a lot of advertisements, and you'll be receiving a lot of literature in the mail about all kinds of things called Medicare Advantage plans. We're already being barraged with advertisements, can't seem to get away from them, and they can be kind of confusing. So in the second round of discussion, we'll be talking about the real details of Medicare Advantage, why one would want to switch to an Advantage plan, why one might not want to switch to a plan. But in any case, that's also called the annual enrollment period. I'm laying these out for you because it can be very confusing, and a person just needs to know about all these different names and acronyms. I point out that there is something called the Medicare and You Handbook for those who are already in Medicare. There's great detail about that. There's also something called Medicare.gov for those who are using the internet, which provides a lot of detail about all of these things. I'm just basically able to summarize them in a brief period tonight. Then the open enrollment period goes from January 1 to March 31. So if you're already enrolled in a Medicare Advantage plan, let's say you might use it for a month or two and say, I really didn't understand it, I'm not really happy with it, can I change out without having to wait till the next annual enrollment period? The answer is yes, you can switch out during the period January 1 through March 31. So that's yet another acronym of OEP. Then we have special enrollment periods that people can enroll in. Let's say you lose employer coverage or you're leaving your job. It's a time that now triggers a SEP, or special enrollment period. You're losing spousal coverage. If you're changing for other reasons, you're changing geographically, you're moving to a different area, you have the right to then enroll in different plans during that period. There's also something called the general enrollment period. It's a little more confusing and don't want to take too much time to get into it, but that kind of is a catch-all for anything else that's happening. If you don't have a special enrollment period, you haven't signed up for Part A or B in a timely manner, etc. There's something called the general enrollment period. So with that, we'll move on to the next slide. So Medicare basics. You basically, again, just to reiterate, we're talking about Medicare, which will cover you when you turn age 65. If you have Lou Gehrig's disease, if you have end-stage renal disease, you can get Medicare coverage even under the age of 65. You have SSDI, Social Security disability, you can't work, you can get on Medicare. Also something called railroad benefits. In all my years around this area, I really have not run into anyone who has railroad benefits, probably much more prevalent in other geographic areas of the country. So there's Part A and B are going to be your Medicare, your federal Medicare benefits. Part A is going to cover hospital, short-term nursing, some short-term acute home health, and hospice, up to 12 and possibly as far as 24 months. Hospice is basically more considered terminal and palliative care for people. So that's the Part A. Part B gets into all the outpatient, ambulatory, diagnostic, and therapy. So if you've signed up for Medicare, you're going to get a card, at least with Part A, probably with Part B. I'll be going into some detail about why people might not have Part B yet. And that's usually most associated with people who are still working and have insurance through their employer. Then we'll talk about, again, you should have a prescription drug plan. We'll get into the details of that. Some people sometimes ask, why do I need prescription drug plans? I take one or two basic medications and I'm able to get them for a very, low price at a Walmart or a Costco or whatever. There are reasons why people should have prescription drug plans, and I'll be speaking about them. And then again, after those three, people then start looking at whether to get an Advantage or supplement plan. So I believe we have some details on Part A coming up on the next slide. First, just to give you a little bit of an overview, not particularly great news. There's something called the Hospital Insurance Trust Fund, which is associated with Part A. just to give you a little background, you may see a lot of these in newspapers or in brief snippets on the news. Hospital Insurance Trust Fund is something Congress is going to have to wrangle with very shortly. The full pool of funding is expected to run out in 2026, which is really not that long a period of time. And if they don't correct the Part A, there could be some cuts in Medicare benefits. We'll all pray that's not the case. I happen to be on Medicare myself, so it's certainly of great importance to me. Also, a lot of legislation being bandied about by committees about whether to extend the age of qualification, what kind of benefits can be shaved off, whether they ought to go to some privatization scheme or create block grants by which they can cap the amount of money being paid for Medicare. We'll all pray that that does not happen. It would, certainly negatively affect the population. Just to kind of give you a heads up, not to be the bearer of bad tidings. So with that, I think we now go on to Part A, if I'm not mistaken. And here we are. We talked about it, 65 plus. If you've worked for 40 quarters, 10 years, you and or your spouse are qualified to receive Part A at no expense. There's no premium for Part A. The only time there is if you haven't paid into the Social Security Medicare system. Of course, if you're working and you see things that are taken out of your paycheck before you receive your income, you see that there are deductions for Medicare and for Social Security. So that's how Medicare A gets paid for, and those funds go into the hospital trust fund I was talking about. So most of us are lucky enough not to have to pay for Part A. You did not work here, you did not pay in, you could buy a plan privately, $422 a month. If you compare that to what private insurance is for people in their 50s and 60s, still a good deal. But for those of us who are getting Part A for free, that would be a real shocker. So we're grateful to have Part A for free. And if you paid in for a certain amount of time, you can get it at a reduced rate. Again, Part A will cover your inpatient hospital, your short-term nursing and rehabilitation facility for up to 100 days, but there are copays associated with that. Again, I will be talking about that a little bit later in the presentation. Possibly very short-term skilled nursing if you've been released from a hospital after a short period of time and they feel like they need to continue to monitor your status, and again, hospice. So that's a little bit of what Part A is all about. So we can go on to the next. Now, there's a lot of details in this presentation. So what I'll say right up front is for people who need more information at the end of the presentation or at the end of the two presentations, I'm going to make as much available to you in the way of information as you would like. You could sign up for copies of slides. You can sign up and ask for some supportive materials. There's just a plethora of information out here about Medicare. It's a world unto itself. So I try to summarize it. And I recognize after I make these presentations that it's still kind of overwhelming. It's a lot of information in a short period of time. So please excuse that. I need to move along fairly quickly because we have about 30 slides tonight. But if you're employed by an employer with more than 20 employees, the employer group is the primary payer, and then Medicare becomes secondary. So if you're over 65, you're working, employer should be the first response in terms of paying bills, then Medicare is secondary. There are certainly some booklets that help explain this in much greater detail. One of them is called Should I Get Parts A and B? Another one's called Medicare A and B, who pays first, and it distinguishes all of these things, as you can see in the next bullet. Also talk about if you have less than 20 employees. Often those who are employed by companies with less than 20 employees, they will ask you to get Part B as well, whereas if you were the large employer, it can often be the case that you don't need to get B. And that's important because we pay for Part B. Part A is free, we pay for Part B, a monthly premium. But usually everyone is encouraged to sign up for Part A since it's free. There are some people who have asked me in the past, do I really need to sign up for Part A? And there's no reason not to, except for people who are under 65 working and are contributing money into something called a health savings account, through which you can build up money to use after you're on Medicare to pay for some expenses that you would otherwise have out of pocket. So in the vast majority of cases, you want to get on A. You're trying not to have complications that get in the way of contributing to a health savings account for a longer period of time, then that becomes a different story. I always suggest that people talk with their benefits administrator at their company before acting, because there are so many different insurance plans out there. So with that in mind, here's some more detail. Again, it gets a little more complicated, but once employment ends, you have 8 months to apply for Part B without a penalty. So when you're applying for B, you want to do it within that 8-month period. These are the regulations. To me, it doesn't make a whole lot of sense, frankly, because if I know my employment is ending, I don't want to wait 8 months to apply for Part B. I want to get Part B in place immediately instead of the employer-based insurance that I have. Otherwise, I'm really on the line for all the coverages that are provided by Part B, which we're going to show, in the next slide. But suffice it to say, without getting into the weeds here, I just try to make people aware that there's a lot of this kind of detail out there. Again, you can go to Medicare.gov. You can go to your Medicare and your handbook. You can, as part of what I try to provide when I'm doing educational presentations, you can come to me and I will explain these things and send you different detail should you require it. We'll leave it at that for this slide. So we'll move on to the next slide, please. And again, here's certain important facts. So Part A, your hospital inpatient could be a $1,408 deductible. Then again, a lot of detail. First 60 days, you won't have to pay anything as a copay. So you don't have any kind of a subsidized type of plan to subsidize your Medicare. For instance, Medicare supplement. If you have a Medicare supplement plan, they'll cover that $1,408 deductible. It's one reason why people want to buy Medicare supplement plans, so they don't face that deductible. If you do not have a Medicare supplement plan, you would have a $1,408 deductible, but then the first 60 days free. So that's really good news. Something else I try to point out, a lot of care is now being provided out of what's called observation units. Those can be units set up right within an emergency room, or they can be almost at this point a separate unit of a hospital, maybe down the hallway from the emergency room. It's not counted as being an inpatient. So that's very tricky. I like everyone to be aware of this. Otherwise, you can get into some difficulty. But there's an arcane rule through Medicare where they call it the 3-day inpatient rule, which means if you're not in 3 nights, then you're not going to be covered for the next level of care. So you go to a skilled nursing facility, you have a stroke, they transfer you to a skilled nursing facility. All of a sudden you get a bill. Well, what do you mean? I thought Medicare is going to pay for this. Well, there's the 3-day inpatient rule. If you weren't in for 3 days and didn't get someone to write you an exception, you'll be on the line for that follow-up care. So that's something everyone should be aware of. It can also be billed as Part B rather than Part A, because when you're in an observation unit, you're no longer an inpatient. So you're kind of caught betwixt and between. So under Part B, a person is responsible for 20% of the bill. The other major reason people buy Medicare Supplement or Medicare Advantage policies, and as you're seeing all these advertisements on television, I think you'll probably be hearing them reiterate the fact that Medicare only pays, or at least Part B pays only 80%. You need to buy one of our plans so that you will not be liable for the other 20%. And in effect, an observation unit can be considered Part B. So just beware. Again, skilled nursing facility, days 1 through 20, it will be $0, so you're covered, assuming you've met the 3-day inpatient rule. After that, there are copays, and once again, those are reasons people buy other types of supplemental coverage. So I think that's probably as far as we can get into the weeds on Part A. So we will move right on to Part B. So again, A, hospital, short-term rehab, and nursing. B, anything outpatient or ambulatory, including physician office visits, emergency room, urgent care centers, diagnostic imaging, therapy visits, a lot of stuff being done as Part B. Outpatient surgery, Part B. A lot of surgery is switched to outpatient facilities. Well, you give them your Part B card for any of these services. Medicare Part B will pay 80%. Well, the difference, the 20% that you're responsible for, can be significant. So that is why, again, people look at alternative products to cover their A and B benefits. So we'll go on to what some of the details are of Part B. Most important detail, or maybe not the most, but certainly very important to all of us who are concerned about costs, is that people enrolling in Part B, there is a premium associated. New enrollees at this point, the premium $144.60 a month, and that's based on how much money you make. So there's something called IRMA, income-related monthly average adjustments. There's a table on the very next page. So people, they made it so that people who do earn greater amounts of income will contribute more to the federal budget to help us continue to offer Medicare. So again, that's a very challenging thing. Previously, you started out paying about $105 a month, and then each year you get little inflationary changes. Again, for tonight's purpose, I don't want to get too far into the weeds, but there's something about a lot of the population has their Part B premiums deducted from Social Security. They are therefore held harmless for receiving certain price increases on Part B beyond Social Security COLA increases. The rest of us, would be subject to possibly some additional increase. So you get Medicare at 65, maybe you were paying $490 for your Part B. Well, at this point, you may be up to $150 a month or more, depending on your age, to pay for your Part B. Again, to me, coming from the private insurance industry, great deal, tremendous deal. Medicare is absolutely a fantastic benefit if you look at the prices of care. So it's a little bit about Part B premiums. So again, A, most of us free. Part B, 144 to start, and then you're going up as you age. So if we go to the next page, we will see quickly that there's an IRMA table, I believe, and there it is. Again, I don't expect you to memorize this. You could look this stuff up. You can contact me for more information. But it's basically showing that you can go all the way up. So, you're talking about individuals. If they're earning up to 87,000, it was the 144. Earning 87,000 to 109 as an individual, or conversely 174 to 218 for a household, 2-people household, then your premium's going to be up at 202. So you went up about, I guess that's in the roughly neighborhood of $70. And that's, of course, per person. If you're talking about a household, those prices are per individual. So the two of you in that 2-person household earning 174 to 218 would be charged 202. And as you can see, it goes all the way up to 491.60 for those who are much more well off, shall we say. And I've had people in my class, depending on where I'm holding the class, who kind of go, oh my God, look at this. I'm going to have to pay 491. They are pretty upset about that rise in potential premium. And I say two things. Number one, even at 491, it's less than it would be if you were buying a private insurance plan with good coverage on the open market. Number two, I usually joke that I'll trade places with them. They give me their $500,000. I'll pay that premium. So it's all relative, but this was one way the government, again, is trying to get enough money in to be able to afford to continue to pay out these incredible expenses associated with Medicare. There's more detail here about where you can get information about IRMA and how it's deducted, how it's determined through federal income tax forms, but I'll keep it at this. Some of these slides are really geared to multiple hours of presentation rather than the 1 hour, which we're probably almost halfway through. So we'll go on, we'll move on from that. Again, this is more detail about IRMA. For those who are interested in it, please let me know and I'll provide you with some more of these forms and detail. So we can go on to the very next. Once again, just some more detail about the deductibles. There is a Part B deductible. Once again, that can be covered through some of the Medicare Supplement and Medicare Advantage plans that we'll be talking about next week. Once again, the 80-20 rule for the Part B charges, the list of which we've gone through. So, every time you go, wherever you go, you're going to pay that 20%. Here are just a partial list of some of the Part B services. There's probably about a list that's a page and a half in the Medicare and You Guide. But in addition to some of the things I talked about up there, there's durable medical equipment, outpatient clinics, some preventive services, mental health, nutrition therapy. Now, I will add while we're on this slide, just quickly again, there are a number of preventive services that Medicare beneficiaries are able to get right now. Another great benefit. So you need to be aware of that list. Hopefully your physician's aware of it. There's a lot of screenings with a kind of a preventative focus, shall we say. That was certainly one of the reasons that they put this list of preventive services. This was actually funded through the Affordable Care Act. You hear about the Affordable Care Act, Obamacare, almost totally focused on the 18 to 65 population. the ACA rules don't really apply to Medicare. Medicare is another world in itself, other than they mandated that Medicare include preventive services and screenings through Part B that were totally paid for. So one of the issues, frankly, if we do lose the Affordable Care Act through all the battles that are going on right now politically, the preventive services component of Medicare could be challenged. We will, stand by and hope again that we don't lose those valuable benefits. They're all, again, therapy reimbursement I talk about a little at the bottom. There's something called excess charges. Again, this gets pretty complicated. Sometimes I take 10 minutes to go through this in some of my longer classes. And again, I just try to make people aware, maybe give everyone enough information to be dangerous, or maybe put in a better way, get enough for you to understand so you can look for additional information or clarification, either through Googling this up on a website, going to Medicare and .gov, or whatever other means you have. Again, I'm always happy to provide some of this information to people. You have to be aware that there is something called Medicare assignment. So some physicians maybe participate, physicians or clinics or imaging centers. So one should be aware to ask the question, are you fully participating, partially participating, non-participating? I myself have got caught in that maze by calling an imaging center before I went in. Do you participate, in Medicare or in a particular plan? Oh yeah, we participate, but wasn't full participation. And so they, in effect, were able to charge excess charges. Some of the Medicare supplement policies offer coverage for excess charges, which can mean you have to pay up to 15% more out of pocket, even if Medicare Part B has paid the front end. So I'll leave it at that. Again, a lot of detail. Be aware there's something called excess charges, and that you want to try to avoid those. Ask that question right up front about Medicare participation status. The vast majority will say, yes, I accept Medicare in full, and you won't have to face those potential additional charges. Most physicians are in the Medicare system, so that's another important thing to know. There are a very small minority who either don't accept Medicare or who now run what they call boutique practices. So most of us should certainly be aware of that when we're picking a physician as to, will you accept Medicare? Are you a participating physician? Will you accept Medicare? A good percent of the small percent who don't practice psychiatry feel that the reimbursement through Medicare is just too lacking, and they'd rather just not participate at all. So we'll move on to the next slide. And again, more details. Sometimes these characteristics apply to people. Sometimes they don't. I build it into my presentation based on people asking a lot of questions. Probably the most relevant thing I'm seeing that people talk about is retiree insurance. I run into a lot of people who either work for a big company, maybe work for the government, the county or the state or the federal government. So they have retiree insurance, and their question is, do I need to pay for Part B? Because remember, you have A and B you're paying premiums for. So retiree insurance that you're getting can be just about as good as Part B. And again, I use the term for the first time, and I will be using it more during these presentations, as long as the coverage is what they call creditable or meets the same requirements. So if you work for a very small company, they might say, we'll allow you to keep this retiree insurance, but perhaps it isn't as good as a full plan that's offered by a larger employer or the county government or whomever. So, then you have to figure out which is better. Again, that comes down to talking with your plan benefits administrator to get more detail. Generally speaking, the good retiree insurance I'm seeing can often serve as, let's say, a substitute for Part B, in which case you don't have to pay those Part B premiums. Now, for those who are going to retire and they say, should I keep retiree insurance? For one thing, I'm going to ask is what kind, how good is it? What kind is it? What's the premium? I mean, usually it won't be given for free, not in this day and age. So if your employer says you can stay on my plan, but it's $400 a month in premium, you have to make the decision as to whether by switching to Medicare, you may be able to save some premium. Frankly, when you're talking about Part B plus the supplemental types of coverage, you're probably in the ballpark of $300 a month. So if you're getting a full retiree plan and it's $150, you're probably going to want to stick there. For people on the lower income spectrum, there's something called the Medicare Savings Program. Again, a lot of separate literature regarding that program, but for people under income limits, there are ways that you can get help with your Part B premiums, deductibles, and copays, which can be a real blessing. So let's see if we're on to the next slide at this point. Again, I don't know how many retirees are out there. I'll be happy to provide this additional information, but I think I generally summarized if you have retiree through a group health plan but enrolled in Medicare due to turning 65, then Medicare would pay first. Your group plan would pay second. So the group plan would almost serve as your Medicare supplement type of insurance. As I say in the very first bullet, one plan is like one plan. Each differ. When people ask me, what should I do? What's your advice? I say, if you want to show me the plan you have, I'll give you some advice. But as a general rule, one plan is like one plan. The Federal Employee Health Benefit Program, for instance, there's a link to be able to research, the Federal Employee Health Benefit plans. It's multiple pages with a tremendous amount of detail. So it takes some research, and each plan is different for, whatever organization you work for, and many of them have low option, standard, high option plans. So without really seeing the detail in each plan, it's hard to make an across the board justification as to what to do. So when you retire, get a copy of your plan benefit booklet, call the benefits administrator, and or talk to someone who understands the stuff, such as myself, if I might say. All righty, so with that having been addressed, here's, again, retiree health plan standard. I've looked at some of the plans from the Federal Employee Health Benefits Program, standard plans. My advice to someone, one thing you have to do is you got to stay in network. That's similar to many of the supplemental plans, or most specifically the Medicare Advantage plans, which you'll see are heavily focused on making sure someone stays in network, because these networks have contracts with certain groups of physicians. So if you're in network, the insurer is getting a better deal, you're getting a better deal. Once you go out of network, you're going to be paying more. Again, there was in this particular plan I addressed, the standard FEHB. There was balance billing for at least the non-participating physicians. That wasn't covered like some of the Medicare supplement plans can cover. Emergency room at a 15% copay, which can be significant. Again, the drug plan had 30% coinsurance, gets into doing a comparative analysis with some of the Part D prescription drug plans that we're going to be talking about in about 5 minutes. Urgent care was significant for out-of-network. So again, that was just one example of taking a look at the standard plan and things that a person needs to think about when compared to different Medicare plans. So we'll go on, since that's a lot of detail. Again, do you need Part B? And when I do my 2-hour class, I get into the guts of this. Again, this slide, if you'd like this information, let us know and we'll make that available to you in order to be able to click on and get access to the multiple plans from all the different federal agencies out there. So there are some minor differences between, Medicare Part B and federal employee health coverage. And so one kind of needs to look at what those differences are to see if the Part B coverage is worth it. So we'll leave it at that. And there's one more page and we'll just basically go on. I'm not going to get into the guts of this at this point, but again, there's a lot of distinction if someone is on the federal employee health benefits plan. Let me know. Let Crystal and Catherine know, and we can get you this information. So we will just move on to the next slide, Eliana, please. So now we'll get into the Part D prescription drug plans. So we've taken care of A and B. Do I need to buy a prescription drug plan? Well, first, let's make sure you understand what it is. Most people do buy a prescription drug plan. Again, there's going to be just a tremendous amount of literature and a tremendous amount of advertisements on television as we move into the annual enrollment period, starting basically 2 weeks from today. And that is because there are a lot of different drug plans and people are confused by them. It started in 2006, the government contracts with private health insurance companies. That's getting into the weeds. I want to make sure you understand the detail as it pertains to an individual. I've been asked on a number of occasions which drugs are covered by Medicare. Will it pay for Part B drugs? What is the list of drugs that fall under Part B, which is the government Part B, versus the Part D prescription drug plan for which we have to purchase it at a price? And so that's something sometimes people need to be aware of. Again, there's information on Medicare.gov, in the handbook, etc., which can specify. So, am I taking a biologic, not taking a biologic, gets into a lot of the detail. But in some cases, Part B will cover certain things, especially as relates to people with diabetes, as to some portion of the cost for some of the supplies. So that's as far as we'll go on this slide. And here's the guts of the Part D prescription drug plan. You're going to buy it from one, I think it's on the next page, but when you talk about Part D, D plans, you can get a D plan if you're either eligible for Part A or enrolled in Part B. Now, most people, of course, are going to be both, but they actually do make the distinction. So if you're not eligible for Part A, but somehow have Part B, you can get a prescription drug plan. Or if you're even just eligible for Part So premiums vary by income. They have the same IRMA requirements, but nothing like the expanse. As you recall, talking about Part B, I talked about premiums of $144 up to $490. For this, we're talking about just $13 up to $74.80 in addition, again, depending on what bracket you're in. But most plans, you'll start with a $435 deductible for first $435 out of pocket. Now that's been changing recently with a lot of competition. And that's when you get into the detail of shopping for Part D plans. But the majority of them, probably still the vast majority of them, start with a $435 deductible. Once you hit your deductible, and there's a shared out-of-pocket insurance equation until you get up to a total of $4,020. Again, the Part D gets a little confusing, and I know a lot of people get confused by the coverage gap, otherwise known as the donut hole. When a certain amount of money has been spent, you hit the quote donut hole, at which point the equation for cost sharing differs. Then when the payouts amount to $63.50, which is quite, it's been raised from about 5,000. So that component has gone up, unfortunately. Then after that, there's just a 25 cost share. Or once you hit combined payments of $63.50, you will only have to pay $3.60 for a generic drug, or $9.25, or 5%, whichever is more for brand. And that's really when the complexity comes into it in terms of Part B coverage, is when people have very expensive drugs. Sometimes I've noticed, certainly when you're talking about very expensive cancer treatment drugs, you may get hit with the 5% on a brand drug, which unfortunately, falls outside the realm of your Part D coverage. And that is when people get a little more challenged. There are a few carriers who offer a plan with a zero deductible for tiers 1 and 2. In other words, if all the medications you take fall into tiers 1 and 2, I'll explain that momentarily, then you would not have any deductible, and the copays are very low. So for people who don't have tremendously complicated needs for medications, it can be a very inexpensive proposition, all other things considered. So we'll move on to the next slide. And we will see that standalone drugs really, again, premium, there's two components. There's going to be premium, then there's going to be payment by the type of drug, which is also, each type of drug will be put into a tier. I think that's actually on the next page, but the premiums themselves range from as low as $15 to about $32 a month. That's on the lower end. There's actually high option plans that could be as expensive as about $75 or $80 a month. The only time you'd go into those is if you had a very expensive drug and you found that if you, by going for the high option, your premium is much higher, but they will then charge you a lot less when you pick up that drug, the actual payout monthly when you go to the pharmacy to pay for the drug. So you have to weigh the differences between the premiums and the type of medications you're taking. Happily, from what I've seen over the years, certainly the great majority of people can get coverage in the $15 to $32 a month range and still keep their out-of-pocket costs for the drugs in the different tiers in control. Okay, there's a way of researching your drugs through something called the Medicare Plan Finder. That's on Medicare.gov website. You go to Part D and they'll say, do you want us to help you find a Part D plan? You put in certain basic information, then they will show you anywhere typically from 25 to even 30 different drug plans out there, and they're usually associated with places where pharmacies where you would get your drugs. So they might be associated with CVS or with Walmart or with Rite Aid. Walgreens has some plans. Of course, a lot of them are associated with insurance companies as well. The most popular one, well known anyway, is the AARP/United Healthcare prescription drug plan. Now they, again, as an example, offered two options: a lower option, which is about $27 a month, and a high option, which is somewhere around $67 a month. So you would say, well, why do I want to pay $67 a month in premium if I can pay $27? And you're going to look at those different drug tiers, which you can get through the plan finder, and then you'll determine, all things being equal, yeah, I'd much rather pay the less expensive premium. That will not include, the cost of actually picking up the drug, the copays when you go to the pharmacy. Many drug plans are offered through what are known as Medicare Advantage. They combine, one of the, quote, advantages of a Medicare Advantage plan is that they combine prescription drug with the Medicare Advantage medical coverage. Therefore, they're known as MAPDs. Almost all of them in this region are offered not as just MA plans, but they will combine the MAPD. And that's kind of a little bit of an explanation. And we'll just go on. The other is great detail, but I think we're almost at the end of this presentation. I think we have about 5 minutes left, if I'm not mistaken. So some important factors of Part D, there's something called formularies. Again, you can find this in your research on the Plan Finder. Formularies are lists of drugs approved by particular pharmaceutical companies. You want to make sure your drug is in the formulary. If it isn't, it's not going to be covered unless you file for an exception. You're not going to file for an exception until you're a member of that particular prescription drug plan. So, hopefully you're on the formulary, it will be paid for. There are generally 5 tiers: preferred generic, preferred brand, non-preferred brand, and specialty. We all hope that we're in 1 and 2 because the copays are going to be anywhere from $1 to $10. You get into the 3rd tier, you could be talking about $45 to $47 for a prescription. So I go to the pharmacy, I have a tier 3 drug. The pharmacist gives me the bottle and says that'll be $47, premium aside. Before I forget, just to mention, as I began talking about at the beginning of the presentation, why do I need a Part D plan? And I'm not quite ready to go yet. If you wouldn't mind backing up just for a second, thank you very much. The point you want is, if you don't have a drug plan, you may be able to find a pharmacy. Like I say, sometimes a Costco or Walmart will fill a very inexpensive drug, a high blood pressure med, a cholesterol med, $5. That's it. Why should I pay 15 or 20 premium plus that? I think I'll wait and save it. Well, there are 2 issues very quickly. There are late enrollment penalties. That was my very next bullet. So if you're 65, you get on Medicare, you're blessed, you don't have many health needs, you take some very basic drugs. I don't want to pay those premiums. When you finally have to join the premium is going to be based on approximately 1% per month penalty that you will then have to pay for the rest of your life. More importantly, in my mind, you're not on a drug plan, something happens to you, you now need some expensive drugs. Until you get to the next annual enrollment period, you're paying out of pocket. Retail prices at pharmacies are mind-boggling. So I think it's extremely important to have a prescription drug plan. Next slide. I think we're just about done. Again, this is getting into the weeds about the different things that count towards your coverage gap to be able to get out of the coverage gap and get back to very inexpensive prices. Basically, you just need to know when you're in the gap. There are things that spending will be credited to you to get out of the gap. Some things will not. So for instance, a lot of people say, well, I hear this particular drug, I'm paying $50 for it. In Canada, if I order it, it's $10. Okay, you can go order the drug. There are a whole bunch of other issues about regulation of drugs in other countries, but be that as it may, that cost of that drug, it's typically looking at more expense than 50 versus 10. You may be talking, 200 versus 50 out of the country, but be that as it may, those expenses for purchases of drugs outside the country will not be included in the analysis of your coverage gap. So you'll be stuck in the gap. Over-the-counter drugs don't count. The premiums you spend for your drug plan don't count. Again, there's a lot of detail in here, and since we're finishing up, we're really not able to do so. Let's see if we can roll forward. I think we're at the last few slides for the evening. So if you'll move forward with the slideshow, please. So these are things about tips to avoid falling into the donut hole. Of course, use lower cost generics whenever possible. Pay attention to the tiers. I mentioned the Medicare Plan Finder. The discussion often turns to, well, if I order a 3-month supply by mail, will I save a lot of money? Frankly, a lot of plans, there's really no savings. I'm beginning to see things as people get more competitive, as the drug plans become more competitive, where there may be some savings. So again, it's worth shopping around. You're talking about using preferred versus non-preferred pharmacies. Quick example, I signed up for the AARP prescription drug plan. I was a user of CVS. Looked at preferred pharmacy list under AARP. CVS is not preferred under AARP. Preferred on a lot of others, but not under AARP. So if I wanted to stay with CVS, it wouldn't have made sense to go AARP. I went AARP, preferred pharmacy, Walgreens. So every pharmacy has a relationship with these different companies relative to whether they're in the preferred pharmacy list. They're usually pretty extensive, but that's something one must pay attention to. If you're of a lower income, you want to be looking through, some other, there's a drug program through the state. There's also something called the State Prescription Drug Assistance Program that'll help if you take very expensive drugs and can't afford them. So we'll move on. I think we're just about at the end. This is a summary of the different costs for Medicare services. I'm not going to walk through them one by one. Anyone who would like a copy of this, I can make it available through Greenbelt Agent. So we'll just leave it at that, as opposed to going back over what I've already discussed for each of these categories of Medicare costs. I think there may be one slide left for the night. I'm going to skip this. I do often get questions about COBRA. Again, if anyone has a COBRA question, please let me know and we'll get that COBRA information to you. Basically, COBRA is something you can go on to if anyone's ever had the experience. If you're, let's say, for instance, terminated from a job, you can choose to go on to COBRA. It's not necessarily the least expensive route in town. In most instances, Medicare will be a much better alternative than a COBRA plan, but I built the COBRA information into this presentation for people who've asked. This is a listing of some things that Medicare is doing, to try and address some of the issues. You hear a lot about the high cost of drugs and the different proposals for trying to make drugs more affordable to the enrollees. Repeal of ACA benefits I spoke about. We're hoping that won't occur. Otherwise, we'll lose a lot of access to preventative health services for free. They'll still be available, but at a cost. Some of the Medicare Advantage plans are looking into providing some home care support services. They really haven't gotten to that level in this region yet. On a national basis, I'm starting to see some regions build a little bit of home care support into their Medicare Advantage plans. Medicare Advantage continues to grow, and we'll talk about that next week. There's a lot greater use of telehealth that will now be, in a lot of cases, reimbursed through Medicare, keep people from having to go to physicians' offices. And of course, given COVID, telehealth is the rage because no one wants to have to go anywhere they don't have to go. They're also continuing to look into competitive bidding for some durable medical equipment, types of supplies, which could, again, be a cost savings both to the government and on a copay basis to the enrollees. One last slide possibly that we'll go to and finish up for the night. So this kind of summarizes it, and this is where we'll leave it until next week. But so in effect, you have your Medicare coverage gaps and exclusions. You've heard, what is paid, what is not paid. So you may have deductibles for A and B we discussed if you buy a Medicare supplement or some Medicare Advantage that's waived. The co-insurances for extended stays. The big one is 20% responsibility for Part D. A lot of the following services are not included in Medicare, contrary to popular belief in some cases, including routine foot care, dental and dentures, eye exams and eyeglasses, hearing exams, hearing aids, acupuncture. Acupuncture has now been approved in the last few months that I'm aware of for use in one particular pain management scenario. No cosmetic surgery, and the hidden elephant in the room, long-term care or chronic care. Medicare does not pay for that. Medicare will only pay the first 100 days in a skilled nursing facility. There are co-pays for some of those days. After that, people are on their own. Tremendous challenge. So we've gone through A, B, and D. You're seeing some of the gaps here. And in the next session, about some of those supplementary, advantage, and savings plans, we're going to see how some of these gaps are addressed. So that's kind of the end of the presentation for tonight on this end.
Thank you for tuning in to Dementia Friendly America's weekly webinar. To contact the Gottlieb Advisory Group directly, please call 301-332-4337, and there are no fees and no obligations to call.